Welcome to our lecture on immunologic testing. In this session, we'll explore how laboratory tests are used to assess immune function and diagnose autoimmune infections and neoplastic diseases. We'll focus on understanding which tests are appropriate for different clinical scenarios, their interpretation, and some common pitfalls. Remember, immunologic testing is not only about detecting antibodies, but about integrating lab results with the patient's history, presentation, and other diagnostic findings. Now, autoimmune panels vary widely among different laboratories, but generally include a range of antibodies associated with autoimmune disease. These panels are helpful in screening for different autoimmune pathologies, but it's important to interpret the results with clinical context. False positives are not uncommon, and sometimes test results do not correlate with disease severity. So these tests can support, but often do not replace a clinical diagnosis. Looking at autoimmune diseases, they affect a significant portion of the population, with at least 10 million Americans living with one of over 80 identified autoimmune illnesses. These conditions can affect any organ system and often have chronic relapsing courses. Recognizing their prevalence helps emphasize the importance of early detection and proper interpretation of laboratory testing in both primary and specialty care settings. Looking at the etiology of autoimmune disease, it is multifactorial. 5 to 10% of the population's affected, and people assigned female at birth are more affected, about 5 times more likely to develop autoimmune conditions than those assigned male at birth. Some contributing factors include genetics, environmental triggers, and infections that alter immune regulation. Microbial agents such as certain bacteria and viruses can modify antigen presentation or trigger molecular mimicry, leading to loss of self-tolerance. Autoimmune diseases occur when the immune system loses tolerance to self, specifically tolerance to self-antigens, producing then antibodies or T cells that attack the body's own tissues. This can result in inflammation or immune complex deposition that damages organs. Depending on the target, diseases can be organ specific, like type 1 diabetes, or systemic, as in lupus. The key takeaway is that autoimmunity represents inappropriate immune activation directed at self structures. Autoimmunity can affect virtually any organ or system. Examples include pemphigus affecting the skin, multiple sclerosis targeting the nervous system, autoimmune hepatitis involving the liver, or even rheumatoid arthritis in the joints. Others, such as Sjogren's syndrome or Goodpasture syndrome, show overlapping features between different organ systems. This diversity in presentation underscores why careful history and targeted serologic testing are critical for an accurate diagnosis. Autoimmune diseases can be broadly categorized as organ-specific or systemic. Organ-specific diseases like Hashimoto's or type 1 diabetes involve an immune attack on a single tissue type. In contrast, a systemic autoimmune disease, such as lupus or rheumatoid arthritis, can affect multiple organ systems through circulating immune complexes or a widespread inflammatory response. Recognizing these patterns helps clinicians select an appropriate lab test. Some organ-specific antibody tests tend to be more precise with lower false positive results. For example, endocrine panels may include antibodies against thyroid peroxidase, insulin, or even adrenal antigens. Hematologic tests include Coombs testing and antiplatelet antibodies, while neurologic panels look for acetylcholine receptor or ganglioside antibodies. GI autoantibodies, such as anti-tissue transglutaminase, are essential for diagnosing celiac disease. Each test should be guided by the suspected organ involvement. Systemic autoimmune tests are less specific and often yield a false positive, requiring strong clinical correlation. Some common systemic markers include ANA for connective tissue disease, ANCA for vasculitis, and rheumatoid factor or anti-CCP for arthritis. These tests can help to narrow a differential, but cannot stand on their own. We always interpret systemic serologies in light of symptoms and other findings to avoid overdiagnosis.